Senator Shaheen, first I want to say thank you so much. We know you are an ally to the mental health community, and we appreciate you coming together and doing a roundtable with us to talk about Medicaid reductions, potential Medicaid reductions. We know that the community mental health centers are the safety net of the state of New Hampshire. We care for the most vulnerable population. We have a front seat. We're the frontline workers. We see the gaps in our system that result in homelessness, substance use, food insecurity, adverse child events. So this is the right group to talk to because we see it firsthand every single day. Medicaid is our lifeline. We rely here at West Central Behavioral Health. We are north of 80% of our payer mix is Medicaid, so we rely on every Medicaid dollar. Most of the community mental health centers run at a loss every year, so we rely on the Medicaid dollars. In other parts of healthcare, they have the ability to diversify their payer mix. They're able to tap into their commercial, Medicare, private insurance. In the community mental health world, we don't have that option. Number one, parity doesn't exist in the mental health world. Yeah. Our commercial payers often do not cover what we consider essential services for our clients. So we don't have that commercial backup to make up financial stability in our payer mix. So this conversation about Medicaid and the impact or the potential impact of reductions or changes in the Medicaid system hits every one of us as providers right at home. So thank you so much for coming to hear our voices.
Well, thank you, and thank you all for taking time to join me this morning. This is part of a series of visits that I've had with people across the state who provide healthcare services, whether it's in the mental health arena, substance misuse, or other healthcare for people who really depend a lot on Medicaid for the payment. And as you know, part of what precipitated this is what the Congress is doing. The House has just put together a bill that would cut Medicaid by about $700 billion. We think it would kick about 13.8 million people off of health care. And in New Hampshire, we think that amounts to about somewhere between 30 and 40,000 people who would lose coverage. As you all know so well, 1 in 7 people in New Hampshire get Medicaid in some form. And I am encouraged that the public now understands how important Medicaid is. And so whether it's long-term care or disabilities or children, a quarter of the babies who are born in New Hampshire are born and because we can afford, we have Medicaid to pay for those births. And then, of course, our Granted Advantage health insurance plan, which really relies on Medicaid. And in fact, I was reading my briefing as I was coming up today, and I looked at the number of people who are enrolled in the Medicaid, the Granted State Advantage program, and it's up to 70,000 this year. So I even called my staff to say, is that number correct? Because every other number I had seen, it was only about the 60,000 range. And it's clear that people understand the benefit that we're getting from all of those Medicaid services. And of course, Lori and I had the chance to work together when she was the commissioner at HHS in the state. So I know how committed she is. And this is an area where I think it's really important for us to make our voices heard. And when I can go back to Washington and talk to my colleagues about what I've heard in New Hampshire about what's going to happen if they make these cuts, it resonates in ways that I think are really important. And it's not just the direct cuts to Medicaid, it's the work requirements that I think are not realistic when we think about not just what it's asking for people to do, but the paperwork involved. And I'm sure Lori can speak to the fact that when we tried the Granted Advantage program, we tried to put in work requirements in New Hampshire that didn't go anywhere because they were too cumbersome to operate. So Again, I'm really here to hear from all of you so that I can take back with me to Washington what a difference it makes here in New Hampshire. And I know, Kristen, we're going to start with you because you're the storyteller.
I do have a story. Yeah, it's an ongoing story. As I will say, I'll preface it by saying, as a public health professional, one of the things that is the truth that I live by is that prevention always costs less than crisis, right? So my story today is a personal story, but one that I think is not unique. And I'm going to ask you to bear with me because I'm a data nerd, and so I have some numbers to share.
Right.
Our youngest daughter, Tink, was diagnosed with type 1 diabetes when she was 15 months old. Type 1 diabetes is an autoimmune condition. It stops the production of insulin in the body, and insulin is an essential hormone that's critically important for metabolizing our food. 100 years ago, it killed children slowly. They starved to death. Or quickly if their blood was too acidic, and it caused multiple organ failure. Contrary to statements made by Secretary Kennedy last week, exercise and a healthy diet will not keep our daughter alive. She needs the insulin. And it's not just insulin. You can't stare at a vial of insulin and suddenly have your blood sugar be in control. There's a whole universe of things around that molecule that's really necessary for people living with type 1 diabetes. So here's the list, assuming we manage well and don't have any hospitalizations throughout the year. This is the annual, how we rack up an annual cost of Tink's supplies and care. She changes an insulin pump set every 2.5 days. That's $9,000 a year. Those pumps take 210 units of insulin per pump, so that's every 2.5 days, $10,500 a year. We buy a purchase of a supply of syringes for insulin injections in case her pump fails, so there's $40. She carries a cell phone that acts as the controller for her insulin pump and the receiver for her continuous glucose monitor. That needs to be updated regularly because the FDA manages the software for those devices. So that's about $700 a year. And then the cell service to keep her on an unlimited data plan is another $660 per year. As is the gold standard for children, she's currently 12 and a half. She wears a continuous glucose monitor. She changes those sets every 7 to 10 days. So that's about $5,200 a year. And there's a transmitter that goes with it that we replace every 90 days. That's $400. We figure we spend about $300 a year on snacks that catch low blood glucose. Those could look like Skittles, they could look like glucose tabs, but something that's a rapid glucose source for her. She has quarterly appointments with her endo team to the tune of about $1,500 in visit bills. She also has to see an eye doctor on an annual basis. That's another couple hundred. She has annual immunology labs to see if she has any other bum luck diseases, because once you have one autoimmune condition, you're at a high level of risk for others. That's another $1,000 a year in lab work. Then just to be sure that we've got a plan B for her care, we also carry blood glucose strips and lancets. Those are about $50 a year. We have to have emergency glucagon kits to treat really dangerous lows. Those would be the ones that require a 911 call or a trip to the ED. Those are $2,000 a year. And then we also pay for psychotherapy because the burden of living with type 1 diabetes has caused a rather substantial anxiety disorder for her. And that's another $3,250. So just the cost of keeping her, what we call a healthy diabadass in our life, is $34,850 per year. Worth noting that we're Coast County residents. The median income in Coast County is just a tiny bit north of that. Fun math. So she was diagnosed when she was 15 months old. If we take really good care of her, her chances of living to 70 are pretty good, as long as we never take a day off from the constant attention that this disease requires. At today's prices, that cumulative cost is $2,387,225 in supplies and care to get her to 70. But there was also a $26,000 ICU stay that we paid almost completely out of pocket when she was diagnosed, because we thought as a young family a high deductible health plan was a good decision. And so most of that came out of pocket. So that's about $2.4 million to get her to 70, assuming no other hospitalizations, no other complications. We never have to worry about expensive pregnancy care if she chooses to have children, and there's never inflation. If we calculate in a 3% cost of living raise on those expenses per year, which frankly is laughable because pharma will never hold it there, it's a lifetime investment of more like $4.8 million. And the chances are really good that anyone in this country would be challenged to shoulder those expenses. including yourself, Senator, who has one of the best healthcare plans in the country, right? And it still leaves out a lot. There's a lot of things I haven't calculated yet. The cost of groceries. When you're constantly counting carbs and paying attention to macros, you find yourself shopping those outer edges of a grocery store where you're eating fresh foods, fresh fruits and vegetables, lean meats, high fiber. Those are all more expensive, and even more expensive when you live at the end of the food supply line like we do in COAS. There's hours of lost work and school time spent on appointments. Our state's closest pediatric endo team is here in Lebanon at the Children's Hospital at Dartmouth. So that's a 2-hour drive from our house in each direction for a 20-minute appointment. She sees her eye doctor in Concord, so similarly 2 hours away. And we've had to find a dentist in Concord that uses trauma-informed practices because she can't be seen by one of the few dentists we have in the country without significant panic attacks. So there's also the gas and the wear and tear on the cars. And the bottom line is type 1 diabetes is an autoimmune disease. It isn't caused by laziness. It's not caused by too much sugar. We haven't found a cause, and as a result, we haven't found a cure yet. And type 1 kids don't cause it, and they can't prevent it. And without these care and supplies, their only outcome is death. That's it, a slow death. Insurance coverage matters a lot when you live with a lifelong disease. I've been fortunate to always have work that provides insurance coverage for our family, but even that comes with a cost. When we're covered by commercial insurers, the premiums for having her added to my policy are about $300 a month. And that's a policy still with high deductibles, co-insurance, and co-pays. And it meant that I spend hours each month on the phone with insurers, healthcare providers, and supply companies fighting over prior authorizations, refill volumes, and even the type of insulin that they would fill for her. Actuaries were making decisions instead of her providers. And so in an absolute fit of pique in November of 22, at 2:00 in the morning, so exhausted and frustrated with fighting with insurance companies over upgrading her pump to a better model that would serve her better, I dumped our family's information into healthcare.gov to see if there was an exchange plan somewhere that maybe I could work with better. I had no illusions that we would qualify for Medicaid because I tried to get her covered by Medicaid when she was diagnosed in 2013, and then our income was too high. And I had since had several promotions at work and knew my income couldn't possibly, except that she did. She qualified for New Hampshire Medicaid because we were in a Medicaid expansion state. What happened next was nothing short of a miracle for our family. Thinking about it, I still get goosebumps. I don't fight with insurance companies anymore. Her supplies, her care, they're covered at 100%. I can't tell you what it costs right now because I never see an explanation of benefits. I never see the claims processing. I give her Medicaid card to the people who need it, and she gets what she needs on time when she needs it. In fact, the pharmacy that fills her supplies calls me and says, "Hey, you're due for a refill. Would you like us to send it?" And I say, "Yes, please. That'd be great. Thanks." And I'm off the phone in 2 minutes. And now it's under threat. I've had 2.5 years of being able to sleep at night. One of the things we don't talk about a lot when we talk about the cost of care for an individual is what it costs the family around them. And I have not had a solid 8 hours of sleep since 2013. It's disrupted every 2 hours, checking alarms or, doing blood glucose checks. It causes a high level of stress. We don't go on vacations as a family because this disease costs so much money. The only reason Tink has started to go to camp is because there's a diabetes camp that scholarships her to attend so that she can be with other kids with diabetes, with caregivers who know what they're doing. We're a single income family because my husband needs to be available to respond if something happens with her. There's a lot that wraps around that. And we've had like a 2.5 year reprieve because she's been able to be covered by New Hampshire Medicaid. Her coverage was only possible because of expansion. And if we're a state that has trigger laws, right? So if Medicaid falls apart at the federal level, New Hampshire falls apart too. And that big, beautiful bill that passed the House in the middle of the night last week doesn't just threaten to end Medicaid expansion. It also eliminates really important research that we hope is getting us towards a cure. We do incredible work right here in New Hampshire, in Regen Valley, down in Manchester, studying what causes this disease and how to fight it. So that's my personal story. Professionally, I would say I also see the impact that these cuts are going to make. And I'm so pleased to see the number of agencies represented around the table today. In my role, I serve as the director of the North Country Public Health Network. COAS and Northern Grafton are the poorest counties, poorest parts of our state.
Right.
We regularly compete with Upper Valley, with the Monadnock region, with Carroll for being the oldest part of the state, with the highest, and for sure, Tawas County has the highest prevalence rates for disease and disability. So, you know, when I think about what this could potentially mean for those rural residents, we talk a lot in our work in the North Country about the fact that in our space, we're 96.7% white non-Hispanic. People think we're not a very diverse place. We don't have equity issues, but in truth, the equity issues for our rural parts of New Hampshire are rurality and poverty. And frankly, I think when we start talking about cutting Medicaid, we're talking about harming people who are already way behind the eight ball. They're already disadvantaged. And we take folks from being in that space of having preventative care to now relying on crisis care. And they really disrupts their lives, but it also disrupts the state. You know, if you're not well, you're not working, you're not a productive part of the economic turn of the state. If you are relying on charity plans and philanthropic organizations to get by every week and the food bank to get by every week, there's no room left over in your life to be productive, contributing members of society, and whatever that looks like, right? So I think there's a lot of ripple effect that comes from decisions like Medicaid cuts. We know we're living with a mental health epidemic following the pandemic. There are a lot of people who struggled a lot through COVID and have not recovered from that yet. The work your agencies are doing, it's essential to helping people reach a place of health again. And we're still behind the eight ball. If we lose Medicaid, and the numbers you're talking about, 70,000 people in the state of New Hampshire, I'm really fearful about what that will mean for a lot of other stack-on impact within the state.
Well, thank you so much for being so eloquent and for being such a data nerd, because it's really helpful. And just know, I don't know if you're probably not aware of this. My oldest granddaughter has type 1. And so,
Breakthrough conference last year. Yeah.
So I know the stories of what you've gone through and how hard it is. And, you know, the fact that every year you have to fight with the insurance company to say that, oh, well, she still has type 1. It's like, yes, because this is not a disease that goes away.
There's still no cure.
And, you know, the fights about whether you can, they won't cover a certain type of insulin. Ellie is now 24 and she's out in California. And this spring she went to the drugstore to fill her insulin prescription, and she didn't know that the insurance company had decided that they were no longer going to fill that insulin. And so the other insulin that she'd been on made her sick. And so she called home, and her mother said, we'll just pay for it, and we'll fight with the insurance company later. And of course, it was going to cost over $1,000 for that one prescription. So that's, as you point out so eloquently, that's what so many people are going through on a daily basis. And Medicaid is a lifeline. And so with that as a start, I know the rest of you are also dealing with concerns about what happens if we lose Medicaid and what we can do to help address that. So I don't know if anybody wants to chime in after that.
I think you make a really great point when it comes to the work requirement, because I think that is a reality that we're going to be facing in the near future. And although some of us will take out, you know, will feel like we have a waiver, because they will waive people that have mental illness or disabilities or certain long-term care residents, but there's still going to be the requirement to prove that. And that is what we're going to have the issue with, is that every year we're going to have to show that our client who gets, you know, ACT services through our ACT team still has schizophrenia, right? And they are still waived in that program, that the residents of a nursing home that are citizens that live with disabilities every year, similar to the READY process that we do for the DD waiver, for example, we are going to have to show and prove that we have a waiver from the work requirement. And that's going to fall on the nonprofits in this room,
Right.
all of us, all of the case managers, to redo that paperwork every year when we know that the conditions that our clients suffer from are irreversible. They're not going to be cured. They're not going to be able to fulfill a work requirement. But still, every year we're going to have clients that are kicked off Medicaid because they didn't get the paperwork in time, and then we're going to have to re-enroll them. That is one of our big concerns, that the paperwork burden on a work requirement is going to fall on already strapped nonprofits
Right.
in Upper Valley.
And to add to what Lori said, once you're kicked off Medicaid, it takes a great act to get back on Medicaid. It is not easy to just get back on. And there's long periods of time when you're fighting to get back on, and then there's delays and there's gaps. And there's, in our world, billing problems and billing challenges. And you're providing services with no revenue coming in because you need to. But the reality is the person needs their Medicaid for all kinds of reasons.
And, it's not clear to me because I haven't had a chance to read and to see greater detail on the House bill. So some of you may know more than I do at this point, but they're talking about not enrolling people unless you can show you have a job. So it's not just that you get on Medicaid and then you have to go to work. It is that you can't get on unless you can show you're either doing the community benefit or the work requirement. And again, that's part of the paperwork burden.
It's even more than that. We know that mental health and addiction difficulties are incredibly common. It's lots and lots of people.
Right.
And we also know that we know a tremendous amount about how to help people. And those of us in the room and others have been working in partnership for years to try to increase timely access to high quality care. People need the care when they need it. And any obstacle to care gets in the way. And people with substance use difficulties and psychiatric difficulties, people that are severely psychiatrically ill, you can prove that they don't need to do the work. But people that are less ill are also much more likely to be not organized enough to fill out the paperwork, to not be aware of what's going on, to be less likely to get on Medicaid or stay on Medicaid if there's a work requirement. And then that will just lead them to have worse outcomes, be in the emergency room. And we need a steady system to support people over time, and that requires just ongoing funding. So we're really grateful for your ongoing voice in helping Medicaid and other topics such as SNAP and other things that also support people.
Well, that's right. We didn't even talk about what the bill is going to do to the SNAP program, which is going to be significant cuts also.
You have ideas about what we can do that would be helpful? We'd love to hear those.
I do. I think, my current mantra is call everyone. Talk to your social media networks, let them know how concerned you are, what this means. Talk to your local officials. Sorry, Mayor. Talk to your state legislators. I understand this is a federal thing, but they need to hear from people across the country. Call the governor's office, call anybody who, and your neighbors, your colleagues at work, and tell them to do the same thing. I think about when the Affordable Care Act was under attack in 2017, and we weren't at all sure that we were going to keep it. That one of the things that I know made the difference was the fact that people across the country just said, we can't let this go. And I remember all of the forums we did in New Hampshire, Senator Hassan and I, you may remember those too, Lori, where hundreds of people turned out and told their stories and talked about the difference that it made in their lives. And that's the kind of messaging we've got to do now to say that this is not acceptable. We can't have this. And, this is the obvious point. And my view is sometimes you can get people to do things for cost-effective reasons when you can't get them to do things for the right reason or the moral reason. But this is going to cost more money. This is not going to save money. And, that's what I've heard everywhere I've been. People say, well, yeah, but so you get kicked off Medicaid and what do? You wind up in an emergency room, you wind up in jail, you wind up someplace where it's going to cost more money than preventive care. As you point out, prevention may be expensive, but it's a whole lot cheaper than Kara, I remember when I was first running for the Senate, and they were talking about the fact that you could not, if you had a diabetic attack and you wound up in the hospital, you could be covered. That would be paid for by Medicaid, but you couldn't get the consultation for how to stay out of the hospital and have that paid for. And that's much cheaper than the hospital visit. I mean, it's like, so it makes no sense. And this is an investment that we need to make.
And without it, everyone's going to feel it. So I'll say from the city perspective, there's a ripple effect too, right? Like we know that, without preventative treatment mechanisms, people rely on emergency services. We added 4 firefighters this year because we have the highest call volume per firefighter per state, or per firefighter per year in the state.
Really?
So we have 176
Wow.
calls per firefighter per year right now. The overwhelming majority of that is emergency medical services. And this is why we've been trying to do innovative programs like the community health nurses, our community EMS to treat non-emergent care, because the system is failing. Even the system right now is still failing.
Yeah.
So so you talk about the ripple effects of cutting Medicaid. It's going to lead to increased homelessness. People will try and pay their bills and will lose their house over it or lose their jobs because they're spending so much time trying to get emergency care. It's going to overwhelm an already overwhelmed emergency department at DH, and it could be wherever. Like the state will get overwhelmed. So, and this is kind of important, not just for the impact on our healthcare partners, which is already severe, but straight to our emergency services in the city. So right now, our firefighters, when they run an EMS call, they're spending a disproportionate amount of time waiting at DH. And why? It's not DH's fault. They're putting people in the emergency room corridors to try and get them all through. Bless their hearts for working as hard as I've seen them work, because it's incredible to see. But so they have to wait because they have to discharge their patient, and they have to fill out all the paperwork. So that's 2-4 firefighters per ambulance, depending on the call, that's just sitting there out of service. So what does that mean? Well, now it means overtime. It means delayed response. And that's currently, and we're not in a position to be able to add more firefighters at this point. And the volume has increased such that when we added 4 firefighters, we're like, okay, we'll take this down about 155 calls per firefighter. We're going to be back right up to 172. It's the latest I heard from our union. And that's right now. This is going to get substantially worse with cuts to Medicaid, whether it's related to substance use treatment, whether it's, just regular care that we should be providing. And we're either going to have to raise taxes to pay for additional positions, or people will suffer. And it's not just the people that Medicaid supports. It's going to be, the person who has commercial insurance, but our ambulance is tied up and there's no one from Hartford to provide, mutual aid. And, those are situations where maybe it's 6 minutes versus 2 or 10 minutes versus 6. But if that person's in a heart attack, God help them. And it's just part of a pattern of downshifting we've seen across our services, not just with fire, but with police. For example, I'm sure everyone up here has seen, we had the wrong way driver yesterday, and that wasn't taken care of by the state, even though it was a highway. That was Lebanon. That was LPD, LFD, pulling that poor woman out of her car, along with the 2 other emergency response, or people who needed emergency response that then went to DH. And there will be ripple effects that everyone feels. And, again, so it's it will cost everyone more money to not do this, because, as everyone said far better than I am, preventative care is a whole lot cheaper. And that's really, from a city perspective, where our concern is at. We are not going to let people suffer. So as a consequence, if Medicaid gets cut, it will likely ripple through the state budget, because the state of New Hampshire's Medicaid budget is 95% federal funded. So our human services budget, which is already doubled or more, well, we now do $200,000 a year just for house assistance. We'll probably have to increase substantially just to cover people coming to us because they have nowhere else to go. And it's, we're not going to let them suffer if we have the power to fix that.
Do the firefighters and EMS respond just to the city of Lebanon, or do you cover a number of surrounding communities?
The bulk of our response is to the city of Lebanon, but we are part of mutual aid, so we will respond to Hanover, Hartford, and, Enfield. We have mutual aid agreements with all of those groups. We do have contracts with APD to provide emergent medical transportation from APD to like DH or other facilities. But the bulk of our calls are Lebanon based, and I think that's just kind of we're a hub of the Upper Valley.
Mm-hmm. Sure.
People are coming here for commercial, business, whatever, shopping, and that has an impact on the demand for our services. But certainly, and we've looked at it for demand for human services. It's overwhelmingly Lebanon, residents who are relying on our services, and I think it's a deeply flawed misunderstanding of who, by and large, is on plan, social assistance of any kind. Because we've been fighting this a lot, actually, as it relates to the Families Flourish Northeast and the work we've been doing with them, trying to get their substance use residential treatment facility up and running. But people are like, you're going to be sending people from Maine and all over. It's not going to be Lebanon. It's like, no, it is Lebanon. 15% of Grafton County is covered. Adults are covered by Medicaid. Was 31.7% of children. I was looking at this, 86,000 kids in New Hampshire as of 2024, right? That doesn't even count expansion, which is now up to 70. I'm continuing on my soapbox, admittedly, but the whole argument is we want to cut waste and we want to ensure that, people are being healthy and productive members of society, but then you put roadblock after roadblock after roadblock to that instead of finding a process that actually does that. You don't start with work now and everything will be okay. And I get to be a little snarky because I don't have to take too much time, but it's just what do you, with kids, you put in a work requirement, you want to send them back to the mines? Because that's kind of their attitude. And it's just very frustrating to watch and see. And it's only going to get worse as this goes on because it's not going to stop at Medicaid.
Well, and you talked about substance misuse, and I know that folks here involved in that issue, the single biggest payer for substance misuse treatment is Medicaid. So, as we talk about, what are the ramifications?
Sure. And I think that's actually something that we should celebrate rather than look at as, oh my gosh, we're spending so much money on those people. It's the ability to provide the right kind of treatment for people at the right stage in their addiction process that gets them back to being productive, that helps them move through this process. And as Lori pointed out, there really isn't parity in their systems, so that it is a Medicaid system that is going to provide that. And the benefit to folks within our community has been tremendous.
It has been, and that has, again, ripple effects throughout the community, especially at a time when we can't get enough workers, and to be able to have that pool of people who are now back in the workforce is huge.
If I could just sort of tell one anecdote, my eye doctor several years ago told me a story about a man who came to him looking for support. He had a job offer that he was really excited about. However, the job required him to be able to drive there. He couldn't get there on public transportation. And he couldn't get his driver's license renewed because he couldn't pass the eye test. He needed a pair of glasses. And they were expensive enough that he couldn't afford them until he got the job. But he couldn't get the job until he could get the glasses. A $500 pair of glasses was preventing this man from becoming productive and getting off Medicaid. Medicaid wouldn't pay for it. These are the kinds of perverse systems that we have in place that these ideas that people are going to prove that they have a job before they can get the benefit. The fact that people have to turn down raises in their job because that extra 50 cents an hour is going to cost them all of the supports that they have, that keep a roof over their children's heads, that keep food in their mouths, that keep them thriving. These are the things that create the problems that lead to this just sort of cycle of misery.
Right.
If we could believe in people that they want to improve their financial situation and their stability, and we could give them a hand up as they move along, they are going to get to the place where they are now independent and operating as effectively as they can with whatever chronic conditions they may have. But we make it impossible for that to happen by taking things away at the very moment that they need them.
It's a punishment for poverty, really.
That's a
And,
good way to
you know,
put
I
it.
think-
Or for illness.
Yeah, punishment for poverty or illness. And I know we're not supposed to use the equity word in public health, Alice, so you'll forgive me doing it, but here it is. Our role as public health professionals is to address health inequality and health inequity. And that means a systemic collection of data to demonstrate where the need is, and then a subsequent collection of data to demonstrate that the initiatives we've implemented are having a positive effect on those inequities, right? But like one of our primary sources of data collection in the healthcare space and mental health space is claims data. The simple fact of the matter is if you drop people off Medicaid, you lack the claims data to show there's a problem. Then it's very easy to say, there's no problem. There's no data that supports there's a problem, so we don't have to fix the problem. Despite the fact that anecdotally, everyone and their brother can say, we've got a problem because EMS is getting called out more frequently, or that there are more people sleeping in our parks, or there are more people who are walking around with massive sores on their feet from disease that's gone untreated. And I worry a lot as a data nerd about the disappearance of data that demonstrates the need that exists. And New Hampshire, I think, is an interestingly vulnerable state because we're one of the healthiest states in the union. We're small, but we're fortunate to be one of the older states that's got
One of the higher
education
income
attainment.
states. Yeah.
But that's in the aggregate, right?
Yes, right.
And if you peel off the southern tier, the sort of Boston overflow, or as we do in public health, we take Lebanon and give it to Alice.
Right.
So that I take Haverhill North because North Grafton, and Craig, Northern Grafton is so much more like Coas County in terms of the socioeconomic status, the age, the average educational attainment. Our median income in Coas is 60% of the median income of the state of New Hampshire. There's absolutely abject poverty around this state. And the further you move into the rural spaces, the worse it is. My public health region covers 35% of the state's geography, 3.5% of the state's population. And so even then, when you start talking about resources that we often talk about on a per capita basis, right? How many calls per firefighter, how many dollars per Medicaid beneficiary, that's not taking into account the cost of actually penetrating those resources deep into the region to reach the people who need them and help them use them. My closest endocrinologist is 2 hours from my home. Thank God I have a vehicle that I can use to get back and forth, and a job that's flexible enough that lets me take a half a day to whip down and back to DH. Not everybody can do that. And dentistry, we're hurting horribly with dentistry in New Hampshire. We've added adult dental care to the New Hampshire Medicaid program, which is absolutely phenomenal. What a huge step forward. But we didn't add more dentists. So in the rural spaces, it's an even bigger crisis, right? I worry a lot about the disappearing of data. Unfortunately, and how that allows people to further punish poverty and disability.
And unfortunately, the data that we're going to be seeing potentially is an increase in the death rate.
Yeah.
I mean, whether you're looking at a medical death, whether you're looking at a related mental health issue, substance use, suicide, that's what you're going to watch for. And I can't believe there won't be a substantial impact for that. It's we finally got some focus on mental health and substance use. Substance use people, unfortunately, are going to have a harder time with that work-related requirement because it's not as easy for those folks to get qualified. Not that it's easy for the mental health side, but it's harder for the substance use folks to be qualified to say that they shouldn't be working because their disease process is stopping them from being able to do that. But the idea that we finally have some limelight on children after COVID-19, we finally have some, I mean, you can't throw a stone that isn't something about mental health, substance use now, you know, for the longest time was under the, you know, the radar. And now here we are. And we're about to embark on where everything's going to go back under the, you know, because we won't be able to pay for it. You know, the people will not be able to seek services. And I think that's such a backwards way of dealing with the fact that, yes, should we figure out ways to reduce our budget? Absolutely. But to look at the most vulnerable population that we have in the entire country as the way to deal with that is just, it's absurd. It's just absurd.
Well, and what's even more absurd is that this is not about finding ways to make government more efficient or, you know, because we want to put more money into research so we can find cures. This is about giving a tax break to the wealthiest Americans. Yes. Well, it depends on what gets passed, but I think the bill that they have now is about $4 trillion,
Yeah.
$4.5 trillion.
I just out of the CBO, which is stacked in the wrong direction for a good estimate, from my opinion, is right. Like their own people doing the estimates are like, no, it's going to add, you know, $4-7 trillion worth of deficit for. And trickle down economics doesn't work. Like it never has. I say this as an economist. It does not work because what happens is it just gets stuck in a bank, and you see what's happened over the past. I mean, frankly, it's about 50 years at this point, dating back to the 70s, which is the complete and utter destruction of the middle class at the advantage of not even the upper 1%, the 1/10 of 1%. And you know, to me, like there's not even a listening to the argument that like prevention is the greatest cost savings you can ever have, right? Studied out of California around providing shelter and substance use treatment found that it reduced the cost to municipalities by $7 for every dollar spent on prevention. So, okay, yeah, that's California. I don't know how that inflated that is in New Hampshire, but like even if you discount that by half, you still have a 3.5 to 1 payoff, right? Like anyone in their right mind would be like, if I invest $1, I'll get 3.5 back. Great, here's as much money as I can throw at this. And it's just a completely backwards approach. And I think it gets to, this isn't waste. This isn't, their own research has not identified a single concerted material, source of waste across any of the programs they've reviewed. This is purely about destruction and gutting the government. And it's not going to hurt them because they can pay for it and they can sell a little bit of their Tesla stock or their Amazon stock and make billions. Because we don't tax that either as ordinary income. That's just say they get their 20%. It's going to be all of us paying for it. And it's going to be just destructive on a scale that I don't think people are really fathoming yet. It's going to be generational.
I think the long-term impact is going to be really significant in so many areas. And you talk about the data. I worry about the loss of data too. I was talking to the Raymond Youth Coalition about the fact that they were doing their survey for young people on substance use, and it's no longer on the website, CDC, because they've taken anything that is DEI related is now gone. And so, as you say, if you can't point to the data to show what the problem is, then clearly there must be no problem, right?
So just another slight angle on this is that the result of research is really
Another
terrible.
example.
Not only current studies, but also a generation of young people who have the potential to help us understand what's causing psychiatric illness, what's causing addiction, and how to cut it off at the beginning. One of the great things that I get to do in my job is write up letters for people to go up for academic promotion. Mm-hmm. It's fun to actually see what people do with their lives. But I got someone who was able to be promoted, heard about yesterday, who does suicide prevention research at
Wow.
VA, and has found interventions that actually, make a real difference in keeping people alive. But our VA colleagues are now seeking jobs with us outside of the VA because of the atmosphere there is miserable, and the research in particular is threatened, not only in outside the VA but within the VA, and people are quite concerned about what's going to happen.
Yeah, no, I think that's a really important point, the potential impact. And it's not just the research that is affected. It's, as you say, the scientists and the people who are going to do that research who are now looking at other options for where they're going to make their careers because they're not sure they can do it in the U.S. anymore.
Right.
And it's existing research in place. So in another capacity, right, like we're seeing, they've halted I think it's the R35 mechanism from the NIH, which is pretty innovative grant, which is like, here's a pot of money, established researcher who has clearly demonstrated sound science. And we want you to adapt to a rapidly changing environment and take your research where it may. Right? I mean, some of the other, NIH, DHHS, other structures are still there, but from proposal to first dollar spent, a year is not uncommon. And the R35 mechanism, I hope I'm getting that number right, but the mechanism where it's just like, here's a pot of money to change your research as you see fit, or like the core grants, where it's really designed to provide infrastructure and kind of nimbleness, have all, I know the core grants have all been subject to significant scrutiny and delayed because all of a sudden, hey, we're not going to have site visits. The R35 mechanism has been stopped. And then also, all the non-competing continuations and no cost extensions are the big one right now. Those are, that button's gone. So you can't just be like, look, I didn't spend all my money, but we're doing this, we're going to extend this out a little bit, here's why. And it's not like you get to do that in perpetuity. It was like a one-time free extension because it takes a while to set up the project. But that's gone. And so now there's this, again, another stumbling block, and it's intentional. They want to disrupt research and knowledge and growth, and it will, again, get back to, it's going to decimate the research community because what happens there is, I'm not speaking for DH at this point, but for another organization that I'm affiliated with, but they, if those funding mechanisms stop, we will look at why they're in deficit. We'll say, you know what? You have these two people who are supported on this grant that isn't continuing, and you probably need to lay them off. Or what we're trying to do right now, you can't hire this person until this funding comes back. That's a delay. Mm-hmm. Months of delays. And it's going to, again, have ripple effects across all walks of life, substance use disorder, rural health disparities, which is now just gone as a funding, source. And it's going to, for New Hampshire, it is going to ultimately lead to people dying.
One of the most frustrating things that I find is that all of this isn't based on fact.
Yeah.
So here we are, and we're talking about all this data that we're going to throw at people, and and we're going to convince them that this is the wrong way to go, and it doesn't feel like that because none of it is based on reality or based on the numbers that we're looking at. Prevention is cheaper. Doesn't matter. It's in a purely emotional and political environment. We have to do it. We should keep doing it and keep talking about it. But it's very frustrating to know that even though you can pile on the legitimate facts and you can prove things, it just doesn't seem to move the dial.
Well, and I would add to that. So one of the principles that we're hearing a lot now is, move fast, break it. If it proves to be the wrong move, we can always remake it. That's not true. And we have seen so many times, even in the 25 to 30 years that I've been working in the New Hampshire environment. Maybe you can do that in the private sector under certain circumstances, but in the public sector, you can't break something and then build it back again. How much money was spent trying to get New Hampshire's mental health system back? Mm-hmm. When, right. What was it? 20 years ago, they said, 30 years ago, we had the best mental health system in the country. Mm-hmm. And we got to the place where we had one of the worst. It costs so much money to rebuild that. Our substance misuse treatment system over time. We've built a great system. And then when that particular substance of choice is less of a crisis, we let the system die again. It costs so much money to rebuild these things. We're talking, and I can say it costs a lot from the system's perspective to realize that we made a mistake. But what does it cost in the human lives that we've decided to ignore in that interregnum period?
You know, I had an interesting back and forth with Robert Kennedy Jr., the new Secretary of Health and Human Services, because I'm on the Appropriations Committee and everybody has to, they've been really reluctant to come before the Congress, but, you know, they have to for the budget. So he came in and I was asking him about the state opioid response grants, because that's really important to us. And, you know, he said, well, my family's had all these issues. I've had these issues. And I said, I know. And I would think that would mean that you would really understand why this is so important and why we need to commit to ensuring that the funding is still there. He still wouldn't commit to it, which was very frustrating. Okay. Elizabeth's trying to keep me on time here. But that's what you all say is so true. And it's frustrating. That's why I think, you know, it's important for us to talk to everybody. You know, we need to let people know that this is something that is not acceptable, that we've got to look at what makes more sense long term.
Part of our challenge is that folks are tired.
I know
They're tired for advocating, they're tired for fighting the good fight, and we need to re-energize now more than ever. And because they just feel they've been fighting for so long.
Do you have thoughts about how to re-energize?
I think it's forums like this. I think it's getting the message out. I think it's also like, you know, with the hearings that have taken place in Concord, and then a lot of positivity came out of that. That begins to lay a foundation for some of that, but it's really grassroots. It's really person to person, and
for sure.
And it's telling the story, supporting the story, and encouraging it to continue.
I think too, some of the shadow hearings that are happening in DC are critically important. If it can't happen in an official hearing, getting information out and getting it publicized is so important, especially anytime it can be live. There's so much distrust right now in the public system, and for sure in the public health system. I know for me, I'm tired. I was tired coming out of COVID. I wanted just a heartbeat away from vaccination clinics to catch my breath. And we rolled right into defending the public health system. That's been a several years fight as well. It's under attack within our state in ways that I never thought would be possible. And for sure, some of that undermining started towards the end of President Trump's first term. And it's exacerbated right now in the proposals that are coming away. When I look at the reorganization of the Department of Health and Human Services at the federal level, it's terrifying, frankly. Thinking about programs like LIHEAP going away, a complete defunding of healthcare workforce development efforts. Part of my role is to be the director of the Northern New Hampshire Area Health Education Center, and we've always had to come back and defend the AHEC budgets, but it feels different this year. And it's exhausting to be part of that fight at the policy level while you're still trying to do the work with your feet on the ground.
Sure.
In your own communities, and you can project what the impact is going to be in every conversation you have with a neighbor, every conversation you have with someone who's looking for a place to put mom, and you can't get anybody into long-term care facilities because they're backed up, because there's no good community supports to catch them. It's so commingled, it's so intertwined, and to look at the proposed list of cuts and shuffles and shifts to create AHA, it's watching a complete decimation of work for the common good. That's really what I see when I look at those reorganizations. And it's done with this flavor of privilege, to your point, that the folks who are making those proposals and setting that policy, when I think about some of the text that's in the House's bill, it's just written with this flavor of people who've never had to experience what our clients and our community members are experiencing. Yeah. And props to them that they don't have to experience any level of the suffering that some people do. But, you know, we've forgotten, I think, in this country that our government was not formed to be a capitalist enterprise, but instead to protect the common good. And that's what our public systems are about. And when you defund them, it takes a huge slash at the population, right?
Well, and I would add to that so my first comment is there's a deliberate attempt to shift people's thinking away from the notion that we are about the common good, to say that the common good is bad. So that's the underpinning of a lot of this. But in that is the divisiveness of us versus them. And I think that looking for the stories of the people who were pretty sure that all of this that was promised was actually going to benefit them, as they realize that it isn't. When do I go from being one of the protected class to being one of the targets is going to be a moment of a lot of powerful stories are going to come out of those folks who voted for something that they thought was going to save them. And all of a sudden they realize, no, they're not in the group that really was intended to be saved.
Yes,
Just real quick to one of Chris's points earlier about backlogs. So one of the concerns that I have with this legislation or the bill is the change to the retroactive Medicaid coverage from 90 days down to 30 days. So from a long-term care operator's perspective, that 90-day period is really important to us for the purpose of capturing Medicaid costs while that person was deemed Medicaid eligible. And having it drop to 30 days is going to be a huge impact, and I think create even more of a backlog because long-term care operators are going to be really hesitant to admit somebody that isn't fully on the Medicaid program. When we think about Medicaid pending referrals for long-term care providers, Grafton County Nursing Home, just speaking from my perspective, over 50% of our referrals are Medicaid pending. So they're coming to us with the assumption that they're going to qualify for Medicaid and get on the Medicaid program. It doesn't always pan out that way. So with this change, I can see people staying in the hospitals longer until they actually get on the Medicaid program, and it's going to create more backlogs and access to care issues.
The department cannot approve a Medicaid application in 30 days. Not even 90 days at this point, right? So you're talking about people waiting for months in an unpaid hospital bed for thousands of dollars a day because of that.
Yeah, and to the next point too, that the eligibility determinations now, or the redeterminations, there's the legislation calls for every 6 months versus annually. That's going to create more of a backlog on the department and slow down the Medicaid approval process because they're also these same people that are determining eligibility also have to do these redeterminations now for that aspect of it as well. The state of New Hampshire is not equipped to handle that type of task right now. So.
Yeah, no, that's huge. And, one of the things that I've heard from several places here is the impact on our rural hospitals. And if we lose, what that means, not just closing those hospitals, but then the impact in the communities where they exist, because in so many places, they're the biggest employer. That's where the jobs are. And it just, again, it goes back to the prevention versus and where we should be investing.
Ask a question with all these experts here,
Please.
experts on Medicaid, which I'm not. But listening to some of your remarks and also what I've read, a lot of people who are eligible will not get on Medicaid or get off because they can't do the paperwork. And I guess a lot of the Medicaid consumers have difficulty do that and are understaffed. Not-for-profits don't have the staff. Is there any possibility of training volunteers in the Medicaid system who could then maybe even get a credential, a volunteer to do Medicaid enrollment, re-enrollment, and stuff like that? It could be something, it could be statewide.
I'm
Do
going.
it in the Upper Valley?
I'm just going to give you a small story that will not hold you up. I have a stepdaughter who is on Medicaid. She's on the DD waiver, the developmental disability waiver. During my time as commissioner, we had to get her redetermination for Medicaid done. She had turned 21, so she was going on to full Medicaid. And as commissioner, I couldn't figure out how to do it. I was sending myself letters saying, you still have not submitted all of these documentations between me and my husband. The system was so complicated that as commissioner of HHS, I was sitting on our website to do the eligibility determination. I couldn't figure it out.
Our families are waiting 9 months to a year,
Yeah.
fighting the system. It's so broken. It's ridiculous, and it's they're trying to keep up with it. They really are.
Mm-hmm.
And the majority, some like yourself, they really know they've
You know
got
how to
it all
do
together.
it. Yes.
They've got it all together, and they can't figure it
They
out.
can't
And
figure
then that's one extreme, and then we have the other extreme of people that really need lots of support and help, and really even where to begin. And we provide that. That takes time. But then you got to chase it and follow it and remind and chase. And then they're like, how can we get into services? We're waiting a year. It's ridiculous.
Well, and I'd also like to add, sorry.
Go ahead.
Even if those particular challenges could be addressed, one of the things that I am hearing from a lot of organizations across the Upper Valley is that post-COVID, the level of volunteers is is staying very low. The volunteerism base has gone, and everybody is thinking we can solve our problem with volunteers, or we'd like to solve our problem with volunteers. And so I'm just being really blunt with folks when they start talking about filling gaps with volunteers. It's like your pool is smaller and you're competing against a lot more organizations to try to do that. And that's a very specialized expectation for volunteers.
And
It's a great thought. It's a great thought.
one of the things that is clear is that there are changes that we ought to be thinking about making to make the system work better. But that takes real effort. It takes people engaging. It takes talking to people who are involved in the system. It doesn't take a chainsaw. It doesn't take wholesale cutting agencies and people. That doesn't solve the issue. That just makes it worse. What we need to be doing is looking at how do we address what are legitimate problems, because we all know there are some, and we should be working on that. That would be a much better use of time and resources. So, yes. Well, thank you all so much. This has been really helpful to me. This is an ongoing story, as we know. It's going to continue. And your voices are really important. So I very much appreciate all of the time and energy and your willingness to keep at it, because it does make a difference. So thank you.
Thank you.
Thank you.
Thank you.